Okay, so I'll be going over some basics of radiation therapy for prostate cancer, specifically going over SBRT, and also I'll talk about some side effects from prostate cancer radiation. Here are my disclosures for your reference. So a question that I get from almost all my patients is, how does radiation kill cancer? It's intuitive how surgery would treat prostate cancer. Obviously, you're removing a gland, but how does radiation do that? So it turns out that cancer cells are defined by an ability to divide uncontrollably. That's a hallmark of cancer. And what radiation does is it causes significant DNA damage to cellular DNA, and cancer cells are unable to repair that. And what happens when a cancer cell tries to divide with damaged DNA is it dies off, and then the body can clear away the dead cell. So that's how radiation kills cancer. It's effective at killing cancer. It's not just a temporizing or palliative treatment. We're actually trying to cure patients when we use radiation. That's why it's a standard of care option for all forms of prostate cancer. Now, there are two fundamentally different types of prostate cancer radiation treatments. One is external beam radiotherapy, or EBRT, and the other is brachytherapy, or implanted radiation. And I'm going to be focusing on EBRT and specifically a form called SBRT in the remainder of this talk. And so some general principles of EBRT, just to catch everyone up to speed. In EBRT, we are using high energy X-rays that are directed towards the prostate with a linear accelerator. Patients are not radioactive. There's no heating or burning, and it's completely non-invasive. And what you see on the left there are just some images of some linear accelerators we have at UCLA. One is the Meridian device, and another is a Novalis TX device. These are just examples of linear accelerators. Now, there are different types of EBRT that patients may have heard or read about. So EBRT can be delivered in a form of multiple daily doses over a certain time period. And what we've learned over the years is that prostate cancer is actually more susceptible and sensitive to a higher dose per day. And as our technology has evolved, we've been able to do this safely. So briefly, the types of radiation here are conventional fractionation. That's a dose per day of 1.8 to 2 gray, a total of 39 to 45 treatments. Typically, that's 8 to 9 weeks of daily treatment. Moderate hypofractionation is 2.5 to 3 gray per day, 20 to 28 treatments, or 4 to 5.5 weeks. And then SBRT, which will be the bulk of this presentation, 7.25 to 8 gray per day, with 5 total treatments, typically over 1.5 weeks, or treatment every other day. As an aside, people often read about IMRT, and they ask, well, is SBRT IMRT? Am I getting IMRT? So what's IMRT? IMRT is intensity modulated radiotherapy. It refers to the use of advanced radiation technologies to deliver external radiation with high precision. It's a planning and delivery technique. Typically, different beams with different orientations are delivered with varying fluence, or photon flux per unit area, in a way that sculpts the high dose radiation around the target. And so IMRT oftentimes is used interchangeably with conventional fractionation or standard radiation, the long 8 to 9 week course of radiation. But actually, IMRT is used for the other forms of radiation as well. It's just a general principle. So what's SBRT? SBRT is stereotactic body radiotherapy. Another form or acronym for that is SABR, stereotactic ablative radiotherapy. This is a form of radiation treatment where high doses of radiation are given over a period of about 5 treatments or so using advanced imaging and delivery techniques. Many different platforms exist for delivering SBRT, and these are sometimes referred to by their brand name. CyberKnife, Novalis TX, TrueBeam, Meridian. These are just types of SBRT delivery devices. When a patient says, oh, I heard about CyberKnife, my friend got CyberKnife for prostate cancer, that's a type of SBRT device. What's the evidence for SBRT? Well, as of 2022, SBRT is now considered a standard of care option for prostate cancer in the United States. It's supported by multiple high-level studies, and I'll go over 4 of them in some detail. I don't want to dwell on the specifics so much, but just so we're aware of the level of evidence that exists to support SBRT. The first is the HYPO-RT-PC trial. This is a randomized trial out of Sweden. And just to make sure everyone's on the same page here, what a randomized trial is something that's required to show that something becomes a standard of care. It's called level 1 evidence. What this means is a patient comes into the clinic, and they're given an option to enroll on a trial where they're randomized. Basically, a coin is flipped and they either get one type of treatment or the other. There's no bias involved in what treatment is decided. And when we take bias out of the equation, we're able to prove whether something is as effective, whether it has the same side effects, whether it's better, whether it's worse, depending on the way the trial is designed. So the HYPO-RT-PC trial was a randomized trial designed to show that SBRT type radiation would be equally effective as the longer form of radiation. Now, this is a relatively older trial, so they didn't use modern SBRT. They actually used a high dose per day, but it was called ultra hypofractionation rather than SBRT. What did this trial show? So as you can see on the right there, that's what we call a failure-free survival curve. It tells us what percentage of patients are alive without disease at a given time point. You can see that extends out to 10 years after treatment. And what we see is the red curve and the blue curve there are superimposable. There's no difference. Failure-free survival was equivalent between this type of high-dose radiation per day and conventional radiation, which was the 8 to 9 week course. It showed no difference in long-term side effects either. So what does this mean? It provides high-level evidence that treatments using a high dose per day have similar efficacy and long-term side effects as treatments using a low dose per day. Now, the PACE-B trial is the second study I'll mention. It's out of the United Kingdom. It was also a randomized trial. Here, they used modern SBRT. It's a newer trial. And they compared this against that moderate course of radiation as well as the long course of radiation grouped together. And what we see are the early results there that were published in 2019. And you're seeing on the top there are the bowel side effects graphed kind of as a percentage of patients experiencing them out to 20 weeks or 5 months after the radiation. And then the bottom graph is for bladder effects. And again, the blue and the red curves are superimposable. That kind of the circles that you see there are grade 1 side effects, which means minor disturbances. The lower kind of the square and the triangle are more severe side effects. Thankfully, they're rare. And we'll get to the side effects later in the talk. But the main point here is that those curves are superimposable. So the short-term side effects of modern SBRT and either that 4-week course of radiation or the longer course of radiation are equivalent, and patient-reported outcomes are equivalent as well. And I'll show a slide with patient-reported outcomes later in the talk. So again, providing high-level evidence that SBRT with modern treatment techniques is equivalent in terms of side effects, at least in the short term, through 5 months, as other forms of radiotherapy. The third study is a UCLA-Led general consortium study. Here, we pooled data from numerous non-randomized trials, but still trials, run in North America to kind of look at the safety and efficacy of SBRT in a large group of patients, 2,142 patients. We had a median follow-up of 7 years. And what we see there on the right is a biochemical recurrence rate graphed over time. And that's the chance of the cancer coming back in the sense of a PSA rising. It's not survival, it's not death. The survival, thankfully, is extremely high, close to 99%. This is the recurrence rate. And what we can see at 7 years for low-risk prostate cancer, about 4.5%, for favorable intermediate risk, about 8.6%, and for unfavorable intermediate risk, 14.9%. These are all without hormone therapy. What does this mean here? We're talking about long-term follow-up, again, 7 years on average, suggesting modern SBRT is safe and effective. Now, we also looked at side effects. Specifically, we looked at severe side effects because that's oftentimes the main concern. And on the left there is grade 3 or greater GU, genitourinary or urinary side effects. And on the right, grade 3 or greater GI or bowel side effects, gastrointestinal side effects. And what I've done is I've plotted the percentage of patients on different trials of different types of treatments, like the long course of radiation, the intermediate moderate course of radiation, brachytherapy on top of radiation, and looked at the proportion of patients that experience these significant side effects versus the present study, which is at the bottom there, which was for SBRT. What we see is that the 7-year rate of severe GU or urinary toxicity is only 2.4% with SBRT, and the median time of onset, the average time of onset, is about 27 months. So most patients experiencing that type of a side effect relatively early, within 2 years or around 2 years. Grade 3 or greater GI toxicity at 7 years was 0.4%. Again, the median time of onset here, about 31 months, 2.5 years or so. Most patients are experiencing side effects within 3 years for either the bowel or urinary side effects. And the main takeaway is that when you look at that present study, again, a rate at the bottom, it doesn't appear different from any of the other types of radiation, possibly even better than the other types of radiation. It certainly isn't way out to the right, meaning, one of the major concerns early on with SBRT was, is there going to be an issue with this higher dose per day? Doesn't appear to be the case, potentially even otherwise, that there are less side effects, although that hasn't specifically been shown. And then the last study I'll talk about right at the outset here is a UCLA-led SHARP consortium study. This is looking at high-risk prostate cancer. Most of the earlier studies looked at low and intermediate risk prostate cancer and not so much high-risk prostate cancer, although high-risk prostate cancer patients were enrolled on that very first study that showed. And the UCLA-led consortium here pooled data for 7 phase 2 trials of SBRT for high-risk prostate cancer from across the world, together 344 men overall with on average 4 years of follow-up. And again, the curve here is biochemical recurrence-free survival or failure-free survival over time. And you can see that the cure rate at 4 years is 82% overall. And when patients are getting hormone therapy, which they should for high-risk prostate cancer, it goes even higher to 87%. And I would argue as we get new technologies like PSMA PET scan to better stage patients at the outset, we get newer drugs, we get maybe better radiation technologies, that number is only going to get higher. So this is really telling us that SBRT is effective for high-risk prostate cancer. Now, let's talk a little bit about the logistics of SBRT. How is SBRT delivered? And here we got to go back to some basics of external radiation as well. The prostate is actually a moving target. That schematic on the right shows the prostate situated beneath the bladder. The urethra is a tube that runs through the center of the bladder, through the center of the prostate and out, carries urine through to the penis. The rectum is behind the prostate. As the bladder fills up and empties, as the rectum fills up and empties, the prostate actually moves back and forth, up and down, and even left to right. And because of that motion and other inherent uncertainties and considerations with external radiation, we always have to treat not just the prostate that we see, but a margin around the actual clinical target to make sure that we're dosing the prostate accurately. We don't want to miss. The paramount goal is to cure patients. So we treat a margin around the prostate. Now, historically, we've used CT or X-ray guided SBRT with fiducial markers. In this type of a scenario, 3 metal markers called fiducials, they're about the size of a grain of rice, are placed into the prostate in a minor outpatient procedure. They can be tracked with an X-ray or CT scan. That allows us to align to the prostate. So typically we get a CT scan prior to treatment to evaluate anatomy, and then the X-rays are used to align to the prostate since we can see those metal markers. These X-ray images can be repeated during the treatment to make shifts as needed, or we can do the treatment very quickly to minimize the motion effect, like in the span of 3 minutes or so. Now, an MRI can actually show the prostate much better than a CT scan can. That's why men that are getting staged and evaluated for prostate cancer get an MRI scan for evaluation. But the thing is, historically, we've not been able to combine an MRI scanner with a linear accelerator that delivers radiation. That's been an engineering and physics challenge that's only recently been surpassed with the use of MRI-guided linear accelerators. In an MRI-guided SBRT treatment, you can actually see the prostate directly using an onboard MRI. Moreover, when you're using a system such as the Meridian Linac, which we have at UCLA, MRIs can be obtained 4 to 8 times per second to actually track the prostate. You can put this margin around the prostate that can actually allow the beam to automatically turn off if the prostate goes outside that margin. And that allows us to actually shrink that margin that we usually need to a smaller amount, actually 50% as much as we use with the CT-guided SBRT. I'm going to try to show this video here. What you can see is this was a patient that was treated on our device, and the red there outlined is actually the prostate. And what you're seeing is the motion that occurs. See how it's pushed outside of where we think it is as kind of a gas bubble passes through the rectum. That this is happening in real time as patients are being treated. We're just able to see it now with this real-time MRI. What happens is if it goes outside that yellow boundary, the machine automatically turns off. And so that allows us to be more precise and ideally limit side effects. And actually, this is something that we studied in a randomized trial that was very recently conducted called the Mirage trial at UCLA. We actually did a one-to-one randomization. Men that were coming to our clinic, we didn't just treat them on that newer machine. We actually said, well, unfortunately, we want to try to show this is better, so we're going to randomize and flip a coin and treat some patients 50% on the MRI machine and 50% using what we've been doing since 2010 with CT-guided SBRT. And the final results of that trial are not available, but we did present the interim analysis after 100 patients were treated earlier this year at a conference, so I can share those. And you can see the curve or the bar charts on the right there. The percentage of patients experiencing moderate side effects, either GU or urinary or bowel GI side effects, is significantly reduced in patients receiving MRI-guided radiation. And we think that's really because we're able to shrink the margins needed because of the enhanced technology. That's our hypothesis. And so this has changed my approach because although we are still awaiting the final results of this trial, I'm now routinely offering the MRI-guided treatment to patients. And I think we can talk maybe in the question and answer session a little bit afterwards about who's a good candidate and what are the other considerations that go into that in terms of patient experience. And another question that comes up in terms of logistics is, what is SpaceOAR? Lots of patients have heard about this, read about this. They've read about this gel that can protect the rectum. So SpaceOAR is an absorbable hydrogel that can be placed between the rectum and the prostate in an outpatient procedure to physically separate the prostate and the rectum. And the schematic at the top there, you can see before, there's the prostate, the rectum behind it, and outlined in pink there, or shaded in pink, is the high dose region. That's that margin I was talking about. You can't treat just the prostate, you have to treat an area around it. And part of that high dose radiation margin is going to go into the rectum. So the SpaceOAR idea is that you put this gel, it moves and kind of separates physically the prostate and the rectum, and therefore that high dose envelope kind of is going to be in the gel, or at least move significantly away from the rectum. There'll still be dose of radiation going to the rectum, the lower doses that are crossing it, but it does, spare part of the rectum from the high dose radiation. So, what's the evidence for this? It was studied in a randomized trial that was funded by the manufacturer of this gel, Augmenix, or Boston Scientific now, that used conventional radiation. And it was associated with lower grade 2 or greater rectal toxicity. You can see the curves at the bottom. And control means patients that didn't have the SpaceOAR, and the SpaceOAR is referring to the SpaceOAR product, the brand name. And you can see a separation of those curves. The proportion of patients or probability of patients experiencing a moderate bowel toxicity is lower significantly in patients getting placement of the SpaceOAR. Now, those are low numbers overall, and with added technology, hopefully those numbers get even lower and lower. But that the basis of the approval of SpaceOAR by the FDA and coverage by Medicare and many insurances were the results of this randomized trial. Now, who's a good candidate for SpaceOAR? Well, patients with clear evidence of prostate cancer extending outside the capsule of the prostate in the posterior direction are probably not a good candidate for this, because we don't want to displace the cancer. Additionally, it is a procedure to put it in, and so sometimes there can be bleeding infection risk with that. So it's worth a discussion with your radiation oncologist, but oftentimes they can provide some advantages. Now let's talk a little bit about radiation side effects as we move into the second part of this talk. So side effects from radiation can be divided into acute, or kind of within 90 days of radiation, and then late, beyond the 90 days after radiation has completed. Typically, we're concerned about urinary, bowel, and sexual side effects of radiation. Fatigue is another general acute side effect of radiation as well. In terms of acute urinary effects, we refer to something called urinary bother. And what is that? I think it's best answered by looking at this questionnaire called the International Prostate Symptom Score. I actually give this to patients before they come to see me for consult and for follow-up as well. And it kind of defines what the elements of urinary bother are. You can see incomplete emptying, frequency, intermittency, which is pausing during the flow of urine and then starting again. Urgency, how difficult it is to postpone urination, weak stream, straining, and then nocturia, or getting up at night. And so acute urinary bother is essentially this constellation of symptoms. And you can imagine a patient that comes in with zeros across the board let's say these increase by 1 to 2 points across the board in the context of radiation in the short term, we're talking about some urinary bother, but perhaps manageable with medications. Whereas if someone comes in with a 5 across the board, it's going to be pretty difficult if that gets worse because they already have significant symptoms. Now, typically, the most common things are obstructive symptoms like weaker stream, straining, and those are treated with nonsteroidal anti-inflammatory drugs or NSAIDs like ibuprofen or Advil. You can also use urinary medications like tamsulosin, a brand name Flomax. Urinary urgency and frequency can also occur. And sometimes we treat that with something like oxybutynin or other drugs in that class. Incontinence, or the ability to control the flow of, the leakage of urine, that's extremely rare. You can see that's not part of this questionnaire because that's extremely rare with radiation, particularly in the short term. What about bowel effects related to the rectal? And we call that bowel bother also. And this can be really characterized by another questionnaire we give to patients called the EPIC questionnaire. And I've took out a kind of snapshot of the bowel questions there: urgency to have a bowel movement, increased frequency of bowel movements, losing control, bloody stools, and kind of rectal pain. So that constellation of symptoms could define bowel bother. I would say, with the exception of losing control of your stools, which is extremely rare, particularly with modern radiation, to experience anything like that in the short term would be very rare, but the others can certainly happen. Typically, it's less frequent than urinary bother, and it tends to be dominated more by the first two things, their urgency and increased frequency. These diarrhea-like symptoms can be treated with over-the-counter medications like loperamide or Imodium. Rarely is a prescription strength medication needed. And if there is any kind of bloody stools, like an exacerbation of hemorrhoid or pain, something that might be called proctitis, steroid suppositories can be used and can be very helpful. And what I'm showing you here is kind of the time course of these acute side effects. I mentioned I would show this in the context of the PACE-B trial. These are the short-term side effects going through 3 months, 12 weeks. And we can, tackle them stepwise. At the top is urinary incontinence, which I mentioned is very rare. So you can see if we score that as 0 at the baseline, there's a very minor drop. It's not even statistically significant at the 1 month mark, and then it returns clearly to normal by 12 weeks. Same with urinary obstructive symptoms. You can see a dip there. It's more pronounced because those are much more, common for patients to experience, but it's resolved largely at 12 weeks or 3 months after the radiation. And then overall urinary bother, a combination of these two, dips again at 4 weeks and then is resolved at 12 weeks. Bowel bother, also kind of dipping at the 4-week mark and largely returning to normal at 12 weeks. And you can see the magnitude of that drop is less than the magnitude of the urinary bother drop. Sexual side effects we'll talk about. Typically, we're not seeing too many short-term sexual side effects unless patients are going on hormone therapy, although sometimes patients don't feel like engaging in intercourse. They might be more tired. There could be a little bit of pain with ejaculation, and the volume of ejaculate could go down. But essentially, the big picture here is we're looking at short-term side effects that do occur. They tend to peak at the 1 month mark after the radiation is completed and largely are resolved at the 12-week or 3 month mark after the radiation is completed. What about late side effects? Arguably, this is of more importance to people, right? They understand there'll be some short-term side effects, but really, I don't want to deal with late effects. And we can quantify these. You might recall I gave some rates for severe side effects from our UCLA-Led General Consortium study. It was about 2 to 3% for significant urinary effects. We call the cystitis or urethritis. This could be things like pain with urination, very frequent urgency that's not really responding to medications, a very, very weak stream, potentially blood in the urine. These require more intervention, not just the medication, but perhaps a urologist has to look into the bladder, maybe treat something that's there, or maybe we need to use something like hyperbaric oxygen therapy. For bowel effects, actually the rate was about 0.4%, but just being conservative, let's say that's 1% of patients getting a significant severe bowel effect we call proctitis. That could be urgency, typically bleeding. That would be a more common thing. And that might need to be treated with a gastroenterologist actually going into the rectum and perhaps treating or cauterizing something that's burning something that's bleeding, I should say. And again, hyperbaric oxygen treatment could work. And now these are rare, but they do happen. So let's say we treat 200 patients per year. Just to put some numbers on that, that means 4 to 6 patients may ultimately develop this type of a significant urinary effect, that's 2 to 3%, or 2 patients may develop a significant proctitis, 1%. So they happen. They are rare, but obviously they're things that we want to minimize. And then the other thing that patients ask about, rightfully so, is what about the fact that the radiation causes a cancer? Radiation is obviously something that's scary. We don't want to do it to people that don't need it, because yes, there is a very small chance that the DNA damage caused by the radiation might itself incite a cancer. And we're all aware of that from reading things in the news too. So the chance of that is very, very low, and the risk-benefit balance favors using the radiation in someone that has an active cancer, but it is a possibility and is something that just should be going to the consideration when deciding on the type of a treatment. But again, it's extremely rare. And so now let's talk about sexual side effects. Oftentimes that's the number one concern for men, particularly younger men that are getting treated for prostate cancer. The acute sexual side effects I mentioned already are pretty rare. Men on hormone therapy will experience these, but otherwise fairly rare. But there could be a decrease in desire, decrease in interest in intercourse. There is a lower volume of ejaculate when the prostate is treated. But the major long-term side effect is erectile dysfunction. That's also age-related, but it happens in maybe 23% of patients at the 2-year mark after SBRT. And it tends to be a vascular or blood flow-related issue. And you can see some images here pointing out the relevant structures. The neurovascular bundle on the left, that's a constellation of nerves and blood vessels that's running towards the back of the prostate on either side. You'll be familiar with that in the context of people talking about a nerve-sparing procedure. And then the internal pudendal arteries are kind of these blood vessels that drape down in the pelvis and kind of hover close to the prostate. Both of these things are contributing to the development of erections. Obviously, nerves separate, but then these blood flow is contributing. And most of what we think causes radiation-related erectile dysfunction is thought to be from accelerated aging or narrowing of these blood vessels. In that context, medications like sildenafil or Viagra or tadalafil or Cialis will be effective in the vast majority of these patients because they open up and optimize blood flow, but it is a consideration. And although the data are mixed, there are some studies that suggest that maybe using a low daily dose of sildenafil or tadalafil may help maintain blood flow and could be a good prophylactic measure to maintain erections. Typically, these can be taken 6 to 12 months during and after the radiation, really to have the biggest bang for their buck. And so highlighting those side effects, what's down the pike in terms of kind of improving this profile, reducing side effects? That's something we all want to do. And so I would say one is tighter planning margins, like radiating a lower volume of tissue will lead to less side effects. We saw that with the Moyad's MRI-guided radiation trial. Real-time adaptive radiotherapy is a really exciting next frontier in radiation. What that means is patient comes to the table to prepare for radiation. We take a scan. The bladder is a slightly different size or maybe in a slightly different position. The rectum, slightly different size and different position. We actually replan the radiation right there on the table. That's an exciting frontier, and it kind of intuitively makes sense that would allow us to spare side effects as well. And then the final thing is something called radiogenomics, which some may be familiar from watching some other lectures on the PCRI channel. But I'll go into that in a little bit of detail. So radiogenomics is the concept that individual patients may respond differently to radiation, the same way that individual patients may respond differently to different types of medication. That's called pharmacogenomics and is really intuitive to us, right? Different people have different side effects. Well, that should apply to radiation too. And radiogenomics is the area of study looking into that. How does this apply to prostate cancer? So our hypothesis is that maybe when we're delivering these higher doses per day, certain men may react worse to that. And conversely, maybe when you're delivering the lower dose per day, but to a higher total dose, some men react worse to that. And we actually studied this. We looked at DNA from men receiving the long course of radiation and the short course of radiation, SBRT, here and in a hospital in Norway where we have a collaborator. And what we found is a signature that seemed to predict for risk of moderate urinary toxicity in the late timeframe after SBRT. And what you're seeing on the right there is a probability of toxicity curve. In blue are patients predicted to be at low risk of toxicity, though that would be the patients that we don't anticipate would be at very high risk of having a moderate or more severe urinary side effect if we did the SBRT. And indeed, their probability of toxicity, if you follow out that curve, is less than 5%, more than 3 years after the radiation. On the other hand, patients predicted to have a high risk of toxicity in the yellow-orange there, they experience side effects earlier and more frequently. So there, by 3 years, 50% of patients are experiencing these side effects. How could this be used? Well, if we have a patient thinking about SBRT, maybe we check their DNA first and we see, are they at high risk or low risk? And that really could play a role into making a decision for this patient. And we're actually trying to study this. A question is this validated? You just looked at this in a small sample of men treated here in Norway. Yeah, we're trying to validate it. We have an ongoing phase 2 trial at UCLA called the Garuda trial that was opened over a year ago. And that's really designed to validate this test. What we're doing is getting this cheek swab, which can be used to check DNA beforehand, and then trying to counsel patients at high risk, maybe consider another form of treatment, whereas patients at low risk, would be safe to go ahead with SBRT. So that's also an exciting future area. And so I'm going to wrap up there. We'll transition into some question and answers. But first, I'd like to thank my patients, first and foremost, for enriching my daily life. It's a true honor to take care of patients. And also, the ideas I get from research are from working with patients. I can see what are the problems that we need to solve, and that's what motivates me to work to solve those problems. I'd like to thank the PCRI for all the work they do for patients, for their kind invitation to speak here today. I'd like to thank my team at UCLA. Dr. Michael Steinberg is the chair of our department. Dr. Min-Chang Kao is the lead physicist that I work with. And I'd like to thank the entire SBRT team there. I'd like to thank some groups that have funded some of my research, the American Society of Radiation Oncology, the Prostate Cancer Foundation, and the Department of Defense. And thank you very much for your attention.